So welcome back to the fourth part of this antimicrobial in ICU. We have already discussed regarding the pharmacokinetics, pharmacodynamics, MIC, breakpoints. Now it's the time to go forward with this susceptible, resistant, and we will be discussing regarding the time dependent and the concentration dependent antibiotic, what actually they are. So starting with this susceptible resistance, we have already read in the breakpoint that anything below the breakpoint comes to be susceptible. Anything above the breakpoint comes to be resistant. So when antibiotic come to be susceptible, the chance of success of treating the infection becomes more. When the antibiotic comes to be resistant, the chance of success become less. Why I'm saying chance of success? Because susceptible doesn't mean it's a cure, total cure. We have seen many of time we are giving a susceptible antibiotic, but the patient is not getting cured because there are lot many paths, lot many obstacles in between it. We have already read this PKPDs, the albumin concentration, the liver function, renal dysfunctions, availability of or the use of the extracorporeal therapies. So we are not discussing here those things. So what I mean to say that susceptible increases the chance of treating the infection. So isolate with MIC less, or if you are dealing with a zone of diameter, the zone of diameter should be above the breakpoint, because we know more the zone of diameter, the better is the drug, or susceptible is the drug, right? Opposite in case of resistant. So isolate with the result within the susceptible category are predicted to have a high chance of treatment success, while in the resistant category are with a low chance of treatment success. So this is nothing new. So next, what we come to the intermediate category. We have seen many antibiotic being given intermediate in the antibiotic susceptibility testing chart, right? And so now we keep apart that colistin, polymyxin be intermediate category. We will be discussing that in the subsequent slide. Now I am talking about a normal drug. Now suppose a levofloxacin is given I, or a cefepime is given I. What I mean by this intermediate category? See, the name suggests कि intermediate means na घर का ना घट का, means nahi wo susceptible, nahi wo resistant. So the name is very clear. The meaning of the name is very clear from the term of the name. So it's intermediate. So what I mean by that the intermediate category is defined with an isolate, with an MIC in between the susceptible category and the resistant category. That means we have a breakpoint, and below which it's susceptible, above which it's resistant. So for some drug, there is a mid zone. If we increase the dose of the drug, then that breakpoint below which it is susceptible, that can be crossed, but it is neither being termed resistant, right? So this is a middle zone whereby increasing the dose of the drug, you can achieve that MIC or that zone of MIC, which is termed as intermediate category, right? So there is a breakpoint below which it's pure susceptible. There is a high chance of success of the treatment. There is another breakpoint below, above which there is very less chance of success. That is resistant. So between the success and resistance, SRR, there is a category that is a I. So if we increase the dose of the drug, then that drug can be sensitive to that organism. Am I clear? I am repeating again that this is a portion of the MIC of a drug which can be achieved with a higher dose, or so two things can be done. One, dose can be increased to go beyond the susceptible MIC, and another is to give a drug where the drug gets concentrated, like levofloxacin comes out through the urine. or we get a cefepime, it comes out through the urine. So there are certain drugs which comes out through the urine. So if we give those drug in certain, if the drug is in the intermediate category, then we can expect a success of treatment. So you see, what when the term was introduced in 2014, what the intermediate category definition was given, that the isolate with an MIC or a zone diameter that approach usually attainable blood and tissue level, for which the rates is lower than the susceptible isolate. It is not like the susceptible isolate, but implies the clinical efficacy in body sites where it is physiologically concentrated, or when a higher than a normal dose of drug can be used. So if we get a cefepime intermediate, then cefepime has a drug regimen starting from 1 gram BD to 2 gram QID, right? We generally use 2 gram TDS. So you can give 1 gram BD, you can give 1 gram TDS, you can give 2 gram BD, you can give 2 gram TDS, and lastly, you can give 2 gram QID. So if you get cefepime I, that means it is in it, this I is not for all drug, right? There are certain CLSI Eucust zone of intermediate for certain drug, where it has been seen that there is a cut mark for susceptible. There is a cut mark beyond which the success or failure is very common. But there is a zone in between these two where the success can be there, but the drug to be used is more than to be used if it would have been a susceptible category, right? So the dose of the drug should be more if than it would have been a susceptible category. If it would have been a susceptible category, we would have gone for a cefepime 1 gram BD. Now अगर I आ गया, intermediate आ गया, that means we have to go for 2 gram BD or 2 gram TDS. But these are achievable MICs, right? So what is not achievable? The MIC beyond which it is resistant, right? So the intermediate category is now it is totally susceptible and has a high treatment or success rate. नहीं, ये resistant है, which has a very poor success rate and is resistant, and there is a treatment failure. It is in between the zone where you can increase the dose without increasing the toxicity and can achieve success which is less than or less assured than the susceptible category, right? Or you can use that drug for a certain anatomical site like urine or CSF where the drug gets concentrated. So if the drug get concentrated or get eliminated from that area, so it may not achieve in the concentration in blood, but the drug concentration is achieved in that particular anatomical site. So if it would have been a blood infection, you would haven't used levofloxacin. But if you have a UTI or a urinary tract infection and the levofloxacin is termed I, then you can increase the dose from 500 to 750 mgod, and you can use for an UTI, because if it is an I, then it would get concentrated in the urine and will achieve that amount of MIC which will guarantee you a success, right? So in 2014, CLSI come with this definition. In 2019, they introduce another term for I. You all may sometimes get in the antibiotic susceptible testing chart, that is susceptible dose dependent. And they introduce this term for cefepime, next for daptomycin, and for ceftaroline also. But now this SDD term is not further used. Now again, they have in 2020, they have come for I. So it is very clear I means a certain zone of MIC which can be achieved by an increased dose than the normal dose of the antibiotic without causing toxicity, or in a certain anatomical position, anatomical location where the drug gets concentrated. Very clear? So this is the takeaway message from this slide. Please don't confuse with polymyxin and colistin. We will be coming to that in the coming slide. I am talking about the intermediate category for the general drug, right? So coming to the next, which is the famous most question. Colistin is I, but why? Right? Now, we have all known that the intermediate means treatment is success more likely if more dose is used, more frequent dose is used, you can say, because more you use the frequent dose, the more will be the concentration, and the infection is at the site where the concentration of the drug is very high, right? Coming to this SDD, we have already. Now coming to the colistin and polymyxin. So what happened? Before 2020, colistin below 2 or equal to 2 would have was termed susceptible. Above 2 was termed resistant. But in 2020, we have two bodies, CLSI and UCAST. You should remember, CLSI took a decision to remove this susceptible category for the lung infection. Okay. So read this first line. The decision by this is quoted from the article which was published where this term for colistin was introduced, right? So this is quote unquote. You can copy paste in the Google and can check. The decision by the CLSI was based primarily on the data suggesting that intravenous polymyxin have limited efficacy of treatment for the treatment of lung infection in mice and patient. What I mean to say that the polymyxin B and polymyxin E, which is another name for colistin, has a very less concentration, rather achieve a very less concentration in the alveolar epithelium after being administered into the systemic circulation, right? I again repeat that polymyxin B and polymyxin E achieve a very low concentration in the alveolar epithelium after being administration IV. Colistin, polymyxin E, never for lung, never. It is the only and only medication for urinary tract infection. What's IDSSA? Polymyxin B, for blood, it's fine. But when it comes to lung or pneumonia, polymyxin B is also a big no, especially if the organism is having an higher MIC, right? So the decision by CLSI was taken by this account that the polymyxin B and the polymyxin E actually achieve a very low concentration in the lung or alveolar epithelium. So what I say that given that a higher polymyxin concentration can be achieved elsewhere in the body, so if you are using the drug for the blood, then polymyxin B stands to be sensitive, right? Or susceptible, right? So if you get an eye and the infection is blood, then that drug is polymyxin B is susceptible, because this intermediate category was basically introduced for the lung infection, right? Am I clear? So the last line, and all these paragraph were quoted and copy paste from that article. So the intermediate category was adapted for colistin and polymyxin B to highlight the low response rate associated with this antimicrobial. So this is for lung infection. So this clinical response is poor as the concentration achieved in the alveolar epithelium is very, very low. So for these two drugs, polymyxin B and polymyxin E, CLSI introduced the category I, but UCAST continue to term susceptible for polymyxin B and polymyxin E, right? So colistin and polymyxin is I according to the CLSI. Less than equal to 2 is not susceptible MIC. It is intermediate category. The reason why it was done, because it achieved a very poor concentration in the lung if administered IV. So you cannot say this drug to be susceptible, because susceptible drugs have a high chance of treatment success, right? So if as it will not achieve a concentration, so the treatment success will be poor. So this drug cannot be termed susceptible for lung infection. But for blood infection, definitely we can term it susceptible. But unfortunately, they will not termed individually for site of infection. So overall, they termed polymyxin B and E as an intermediate category. There is another concept also why this polymyxin B and E is considered intermediate. We will be coming to that in the subsequent slide. So I will be discussing here only. So this is another reason why colistin is termed I, because we generally measure MIC in Vitek 2. We have already discussed we measure MIC in Vitek 2. But why? The UCAST and CLSI had as advised to measure MIC by broth dilution test. Clear? This is a concept I learned from Dr. Parikshit sir. So this slide is also from his PPT, or I will say his lecture. So that this is what sir has told. When we go for MIC by Vitek 2, we can overestimate the organism to be intermediate or susceptible, right? What I mean in MIC you can get an MIC of 1 and it would have been termed intermediate or susceptible. But if you test the same organism by a broth dilution test, then they get a result of MIC 4. So by a Vitek 2, if you are getting a organism susceptible to colistin, better not to say susceptible, rather to say intermediate, because that doesn't give you a sure shot that this drug will act. So if you do that same MIC testing by a broth dilution test, you might get an higher MIC, and which is the real MIC for colistin. That means in one line, if we conclude that the Vitek 2 or the automated system underestimates the MIC and false positively give the drug to be sensitive or susceptible. So better not to call susceptible. So better to call intermediate, because the chance of success for that drug is not sure shot. If you do the same MIC by broth dilution, which is really to be done for colistin, you can get a much higher MIC and the drug may come to be resistant. This is also another cause why the colistin is called intermediate, right?